This is metastatic melanoma. This is stage 4 disease.
Okay.
As long as the liver confirmation comes back, okay? So far the pathologist looks at it and says it looks the same as the one from the lymph node, but we won't have an absolute answer until later on today, okay?
Okay.
But that's what it's looking like now. Stage 4 metastatic melanoma treatments have dramatically changed,
Okay.
okay? 8 years ago, the survival rate was less than 6% at 5 years.
Okay.
Today, that's 63% to 65%.
Okay.
We don't use chemotherapy, as chemotherapy has not been as effective. We use immune therapy. And what that means is we activate your own body system to fight the cancer, or we use target therapy called a BRAF inhibitor. And the points of that drug is it blocks a target found in that cancer itself. So we're going to check to see whether you have that marker or not. I normally like to start people with immune therapy, whether that marker is positive or negative, because immune therapy has had the most robust response rate. And we can always switch to the BRAF inhibitor if the immune therapy doesn't work, okay? With immune therapy, because it works different, you don't get the same side effects that you would get with chemotherapy. You don't get the nausea and vomiting as much, you don't get the hair loss. What you do get is, the way I explain to people is that if we activate the National Guard today in Caldwell and ask them to go to everybody's house to collect guns, okay, they would hit some resistance, right? And a lot of people in Caldwell will be like, hey, you're not taking my guns. Same thing, when we activate your immune system, part of your immune system may tap part of your body. So we monitor your thyroid function. If you get shortness of breath, we get a CT to see whether that's caused by inflammation in the lungs or anything. GI issues, diarrhea, liver enzymes monitoring, kidney, etc., like an autoimmune type process. That's not the most common side effects to occur. Most people tolerate these treatments. Fatigue is one of the issues people have, but that's one of the most severe ones. We can treat most of those side effects with steroids, okay? High dose steroids taper over about a month, okay? And then we can reinitiate the treatment if we need to. But we'll go through a lot of details with the side effects. Today's visit is about the big picture. What is the next couple steps we're gonna do and what we're gonna do to start treatment as soon as possible, okay? So next week, you're gonna come in for an hour session in which we're gonna go through each drug, side effects, benefits. Our APP goes through all of that, and then the plan would be to start treatment in probably 2 weeks. At that point, you would see me before you start in case there's any additionals or questions before we start. So that's kind of the game plan as it is now, okay? I'm having Heather, our research coordinator, look into clinical trials. We have over 150 clinical trials. And I know you might have seen the video on me about this. I have a patient with melanoma around the same age that's, on a trial basis. We're going to see if that trial's open too. But we have options. So this changes dramatics of everything. And so that's the game plan as of now. So I'm going to pause and answer questions.
So so typically melanoma is on the skin, so how many patients have you seen that there's no external evidence of
Quite a few
melanoma?
actually. So what happens is with melanoma is a disease, and the reason it responds to the immune system is an immunological type of disorder. What I mean by that is that people can develop a skin lesion and it could disappear because the body can attack that cancer and made it go away, but by the time it's gone away, it's already spread to someplace else. That's one theory when we look back at patients that we don't have. 2, people can develop melanoma in unusual locations like the cervix or the vaginal area. So those things can happen too. I have quite a few patients that I treat with that too. So it is not common, but it's common enough that we see it.
Have you had any patient with ileal anal anastomosis that had a melanoma?
I think that's very rare. I don't think there's many cases like that. So no.
Okay.
But different locations like vaginal, cervical, all that stuff, yes. GI, I've seen one in the rectal area, but not anastomosis.
Okay. Will that change anything, considering that I am made So immunotherapy for me might be different considering I'm missing a whole bunch of organs that most other people have.
So actually, one of the big side effects is it causes colitis.
I already have colitis.
So that's, you've already had surgery, so the chances of that happening is always a risk and something we watch out for. But I don't treat people differently. I have patients that have autoimmune disorders, and I'll treat them with immune therapy. I'll just put them, if they have symptoms, we put them on a low dose steroids and keep them on steroids for a while. The initial treatment is a combination of 2 immune drugs, and that's when most people have the more difficult side effects of getting through it. After 4 treatments, or every 3 weeks as treatment, we cut down to 1 drug, which is kind of like a maintenance therapy. And that continues for anywhere up to 2 years. The initial studies was continuing to progression, and those are the ones that are the 5-year data. They are doing some studies of stopping the treatment after 2 years.
So is the quality of life good, or do you feel like crap the whole time? I mean, like...
So I have quite a few melanoma patients, and their quality of life is good. Not everybody's the same. Everybody responds differently. Those first 4 cycles is usually when the quality of life is most affected, because we're using 2 different immune drugs, and one of them just revs up your immune system at the highest possible it can take it to. And that one tends to have a lot more of those autoimmune type of side effects. And I push through that because the studies show that even if you had severe side effects, like in the original study with that drug, they had a few patients that couldn't tolerate it. They got severe diarrhea, they just couldn't tolerate it, and they only gave them 2 treatments. 6 months later, their scans were almost completely clean. So at that time, they didn't know how to treat it. Now we know how to treat it with steroids and anti-inflammatories and kind of get you through that process, right? But back then they didn't, and that showed an amazing response in those groups of patients. So and that's why I pushed you through it.
Okay. So my question is, with her not having a colon, aren't most of those meds absorbed through the colon?
So the drugs we're giving?
Yeah. So how would her body absorb those?
These drugs are given through the IV. So the colon doesn't play a role at all. Yeah. So we would talk about getting a port because there are infusions, and the infusions would go on, the combo drugs would go for 4 cycles, and the maintenance drug would go as long as it works. So that could be, it works great and you're on it for the next 5 years and it's doing well, you come in every 2 weeks, you get your infusion for 30 minutes and you go, or it doesn't work after a while and then we have to change to the pills or something different, or other immune drugs.
What's the likelihood of recurrence? What's longitudinal study on this?
When you have stage 4 disease, we're not looking at cure.
It's palliative.
Yes. And that's what we think we're dealing with the liver lesions too. Is as long as liver lesions, which so far appears to be the exact same from a pathology standpoint as the other one, we don't have the final yet. This is not a curable disease as of today. But that's changing. And that's why we do clinical trials and stuff. I mean, literally 8 years from a 6% 5-year survival to 63%. Can you imagine what the change is going to be in 8 years from today or 5 years from today? I am a cup half full guy, but I am going to be honest with you too.
Do you have any idea what caused my cancer?
The most common cause of sun is exposure. So I don't know if the tumor originally started from your astronome. I don't think it did. It probably, you had a skin lesion at some point and then it spread. That's the most common belief in the community.
So any chance that I've had a viral infection in my eye for 4 years and I go in every 3 weeks. There's freckles on the back of my optic, Any chance it originated there? I mean, he hasn't said, but he only checked it like a year ago.
Optic melanoma is
Different.
possible,
It's possible.
but then you see more local.
Right, I don't have any of the symptoms. I mean, a little blurry, but the same thing I've been dealing with for 4 years in that eye.
What treatments are they using?
I just do eye drops and then we taper it and change it and taper it and change it. And
So as long as it's not something immune compromising, which then can increase risk of cancer.